morning, good afternoon, and good evening, depending on the time zone from where you are attending this APPNA MERIT webinar. I am Dr. Farooq Rathore. I'm working as a consultant in rehabilitation medicine at the Shifa Hospital, Karachi, and I will be moderating this session, which revolves around the theme of disability and rehabilitation care in COVID-19. The panelists and the speaker, they represent truly what rehabilitation stands for. This panel is a multidisciplinary panel of different professionals from different parts of the globe. It includes myself, my colleague Dr. Ahmad Qureshi, Dr. Nasir Mansoor, Amir Nisar, Dr. Sahibullah Nasir Mansoor, Dr. Taha Ali, and Ashika from Saudi Arabia. So what we are going to do, that I'm going to ask my colleagues to present their talks first. It will be followed by a panel discussion, and anyone who is interested in asking a question can either write their question in the chat box, or if they want to express themselves in person, they should raise their hand digitally using the Zoom icon, and then we'll unmute them and they can ask questions. So over to you, Dr. Ahmad Zaheer, for the first presentation. Just to give you a background, Dr. Ahmad Zaheer Qureshi is a fellow of College of Physician and Surgeon of Pakistan in the subject of physical medicine rehabilitation. He then obtained fellowship in neurorehabilitation and interventional pain medicine from USA. Right now, he's working as a consultant and medical director of stroke rehabilitation program at King Fahad Medical City, Riyadh, Saudi Arabia. So welcome, Dr. Ahmad Zaheer Qureshi, for your talk. Over to you, please.
Thank you very much, Dr. Farooq. So I'm going to be talking about the collateral effects of COVID-19 pandemic and disability and rehabilitation. And mainly I'm going to be focusing on the tip of the iceberg. So the tip of the iceberg is how COVID-19 situation or pandemic is affecting the care of individuals with disability who don't have COVID-19. So you might be wondering, like, if that is the tip of the iceberg, what is the iceberg itself? That is the long-term sequelae of COVID-19 related disability. We know that COVID-19 is also causing cardiovascular complications and neurological complications. I'm not going to go into detail because it's going to be covered by Dr. Farooq itself. But we are still in the pandemic phase, and it's too early to determine the long-term sequelae of COVID-19 related complications at this stage. So that is why that is the iceberg right ahead. So we've talked about COVID-19 so much. And we've talked about COVID-19 in context of, let's say, what were the effects of COVID-19 on economy and how turbulent it had been on job-related issues. But we haven't really talked about what's happening with non-COVID related patients, what's happening with trauma patients, cancer patients, orthopedic cases. And not to forget what's happening with individuals with disabilities who had been confined to bed at home. Remember that these are the most vulnerable group of patients who had limited access to care even prior to COVID. So thinking beyond COVID, during pandemic, is there no trauma? I can bet if we switch on the television right now, we would find all kinds of activities which may result in disabilities, as is shown in the slide over here. We know that there has been close correlation with cardiovascular events and COVID-19 per se, but what's happening with autoimmune disease related disabilities and demyelinating disease disabilities as well. Similarly, what's happening with neurodegenerative diseases. So have people stopped hurting? Are we not having any shoulder pain, back pain, neck pain? Arthritis, what's happening with those patients. And above all, the most important is what's happening with the individuals who had all the above disabilities even before the COVID pandemic started, because that's a separate pool of patients, what's happening. So yes, it is all happening, but we just don't know the extent of it because we have not measured it yet. So what we have measured so far, there was a report that was published back in actually March 2020. There are up to 2.2 million people experiencing disability suffer collateral damage each day of COVID-19 lockdown in Europe. So that is the tip of an iceberg. I'm going to be talking about, disability care and rehabilitation in two parts. As I understand that majority of the audience is coming from a non-rehab background. So I consider that it's very important to give a background on holistic care and rehabilitation. So it will help with the rest of the discussion and in the webinar. So what is the general perception of rehabilitation? People generally believe that rehab is about physical therapy. It's about moving arms or legs. It's about the care of the chronic, inactive, bedridden, or immobile patients. Or it's about nursing care or rehab of the drug addicts or psychiatric patients, or the care of the terminally ill patients too. But rehabilitation is actually much more bigger and beyond that. So it's important to understand these terminologies. Number one, we need to think in a different dimension when you think of rehabilitation. We need not to consider rehabilitation as a service. It is actually a process. And it is a process of improving the quality of life and function of individual with disabilities. It extends up to social empowerment. So what is physical medicine and rehabilitation? Physical medicine and rehabilitation is a branch of medicine. It is a specialty for the physician, which deals with improving the quality of life, function, and social empowerment of individuals with disabilities. And when we say interdisciplinary rehabilitation, that means it includes the physicians who are involved in disability care, plus all the other disciplines of rehabilitation which work alongside to improve the quality of life and function and social empowerment of individuals with disability. At our center, we have about 12 different rehabilitation services working together for one patient and family being the most important team player. And in other centers, there's pet therapy and music therapy as well. So this slide is actually for all the neurologists out there, neurosurgeons, orthopedic surgeons, spine surgeons, general practitioner, family physicians, plus especially undergraduate and postgraduate medical trainees. That there's very few neurological illness, let's say for example, which do not have any functional impairment. AKA disability, right? So disability management is very goal-oriented. We need to focus on the disabilities, not the disabilities. And we discourage the word, using the word disabled anymore because of the stigma attached to it. And the more appropriate and positive word would be differently abled. It is not system specific or organ specific. We need to go much more beyond the disease and consider effects of disease on the individual and the social perspective of that person too. For example, if we talk about stroke, it's not the brain which had a stroke, it's the patient who had a stroke, right? So having said that, disability is not an illness of an organ or an organ system or an individual. Is actually an illness of the family which is reflected on the society as well. So we need to focus on social empowerment and reintegration. The main focus needs to be quality of life rather than the disease. I usually say that neurology and rehabilitation are to be considered two faces of the same coin. Regardless of this, if we talk about subspecialties and super specialties in general, we have gone to an extent that sometimes there might be a chance that we may lose the human connection when we become super specialized. The reason I say that is that once there's a lot of super specializations, we may become the experts of the disease, but not necessarily the experts of humans who have the disease. And I would like to share that with the help of next example. So two patients, same level of injury, same severity of disease, coming from the same socioeconomic backgrounds, but one is rolling down the road and the other one is rock and roll. Why is that? It's not the disease which is affecting the personality and the environment, but it's also the environment which is affecting the disease as well. So being an expert on a disease may not really have the optimal outcomes unless the factors which are considered, unless the individual factors as well as the society factors are taken into consideration. So I would like to share with one more example. Let's say, for example, Mr. K had a hemiparesis and he presented and he was admitted in the ward 24 hours after his symptoms and he was diagnosed to have stroke. You're there next day in the morning doing rounds and, what is going to be the focus? Is the focus going to be the workup to evaluate the extent and etiology of stroke and work on the secondary prevention of stroke? Or is going to be the neurological impairments as a sequel of stroke as well, because we know that almost 1/3 of the patients, they can have depression, aphasia, visual spatial deficit problems, spasticity, musculoskeletal pain. Half of them may have speech problems and 90% do have weakness. So this is probably, routinely what we are thinking. We not need to have focusing on these impairment from a diagnostic perspective, we need to really go beyond that and see like what we can actually do about it, which involves both the combination of science and arts. So generally speaking, we're in the acute care, where focuses on this area, but I would like to give you a different perspective as to what the patient is usually thinking at this time. So this gentleman is thinking that he has to go back to work as a rickshaw driver. He has to look after a family of 6. And since he won't be able to go back to rickshaw driver, he's thinking that he might be able to set up a fruit selling job, right? Because he has to survive in the community and he has to pay the bills as well. So this is another perspective of looking at the stroke beyond the disease. So we really need to take into consideration as to, what is our goal, what is the patient's goal, and more importantly, what should the goal be? So I believe that creates a bit of background for our further discussion, and I would like to move on to the collateral effects of COVID-19 on disability population per se. And there have been different effects, I would say collateral effects, from a COVID pandemic perspective to non-COVID disability in general. There are individual effects, institutional effects, problems related to access to care, and limitations of rehabilitation. I'm going to touch base finally, and this is in general broader perspective, and after discussing it with colleagues and friends from other parts of the world, more or less similar challenges have been faced. So individual collateral factor had been one of the most important as the fear of hospital, because patients, they were aware that a lot of patients are being treated in the hospitals with COVID-19. So it's very hard, it's sometimes a hard call for the patients to decide, especially for the patients with activity limitations, if they're going to access the hospital or not. For example, and it's different, disability population is slightly different in certain perspective, because UTI or urinary tract infection in general population is very different from a urinary tract infection in a patient with spinal cord injury. Because in a patient with spinal cord injury, the chances of urosepsis is more. It can precipitate spasticity, which can actually limit the functional impairments. The patient may not be able to do transfers as well comfortably as they were able to do before. Similarly, if a person with traumatic brain injury has a UTI and that person has a seizure disorder as well, so there are chances that it may lead to precipitation of seizures. So that may lead to lack of or deprivation of specialized rehabilitation care, because if there are certain patients who can be safely discharged to home, there is a bare minimum level of intervention that we need to do. One of them is, basic training for the patients and their family, provision of equipment like wheelchair, commode chair, orthotic provisions, and basic supplies like oxygen cylinder, tracheostomy care, catheters, diapers, and so on and so forth. And if they're not able to do that, what is the next sequel? What is the next outcome? They might have complications of prolonged immobility, worsening pain, spasticity, contractures, skin problems, sleep problems, hygiene-related issues, malnutrition, and mental effects. The cumulative effect is actually much more bigger than these things, which is social isolation, neglect, and abuse. And here we're not talking about age-related abuse or gender-based abuse. We are talking about disability-related abuse as well, which is independent of age and gender, because many a times patients may not be able to express themselves. They may not have access to care where they can express their concerns. So that is a very highly vulnerable population all over the world. And of course, once they're staying at home, depending upon the medical conditions and medical complications, they can have different complications related to the medical illness. Collateral effects on the family is something huge. It is often under-recognized. In this COVID situation, families are undergoing not only financial constraints, but we need to remember that, even routinely, there is something which is called as caregiver burnout or caregiver fatigue or exhaustion. And one can imagine that during the COVID-19, regardless of, which part of the world we are in, this is something which can be very significant. One might think that since patients are staying at home, so they may be not at risk of COVID-19, but of course their families and, if they're if the people around them are interacting in the community, if they are immunocompromised, let's say if they are malnourished or they're on immunosuppressants, or they have ventilatory or respiratory complications or impairments because of, let's say, tetraplegia or post-COVID or post-stroke related complications, they become high risk for COVID-19, even staying at home too. And for patients who are staying in the hospital, they might be difficult to have them discharged for medical or social reasons. So they're always at a risk of cross-infection because they're staying in the hospital at the same time. So institutional factors is another major collateral factor. It depends upon how do hospitalized prioritize disability care all over the world. So different institutes have different health sectors had different approach, but obviously one common approach was to naturally the acute care was prioritized too. That is also reflected on the fact that as I have discussed with a few of my friends in different parts of the world, many of the inpatient rehabilitation facilities were converted to acute care COVID-19 facilities, and active interventions were carried out for some patients who won't require any, continuous medical and nursing supervision. They were looked into if they can be discharged to alternate facilities or maybe discharged to home care. So overall, it reflected as a limited rehab services in terms of inpatient and outpatient services too. Now, here is the important factor, which would be interesting to see, like how different health systems address that issue, that were like one institute or one rehab facility was shut down in one city or in one region, one province, or all over the country, because it can have collateral effects on the services throughout the area, throughout the catchment area too. So challenges in supply and protective equipment is a major factor because many of the institutes have come across shortages as well. And once that is an issue, you always have to look into the frontliners who are the acute care providers. They need to be obviously be provided protective equipment at all the times. But rehabilitation services are very close contact, intimate kind of services, which requires a lot of physical contact with a constant exposure as well for a certain period of time. So they're also very vulnerable. So that is a catch-22 as to, how do we balance off the protective equipment and redistribute or distribute it between the rehabilitation service provider versus the acute care or the frontliners too. So naturally, the inclination is around in those areas where there were shortages. Of course, the natural inclination was towards the frontliners. Cohorting patients, rehabilitation population is slightly different. They're expected to be mobilized and more active. So cohorting them is another challenge. Similarly, cohorting the staff is another challenge, which I believe that, many rehabilitation facilities across the world would have come across. Rehab is also unique when it comes to therapy services and gyms, because again, it's a very interactive environment. You have people, you have patients coming in and out, you have different service providers coming in and out as well. You have to limit the number of people in a certain area. Of course, social distancing is another challenge. So that is a unique challenge. Not only that, sterilization of the equipment and space, after you're finished, how do we handle that? There are certain guidelines which are already available and published and recommended in certain areas of the world too. Exposure tracing is one of the unique challenges in rehab because of the reasons mentioned above. One of the other major collateral effect is access to care. In majority of the places and health systems, travel restrictions have been in place as well, which poses a great deal of challenge for patients with activity limitations or disabilities, because accessibility has been another major issue as well. So naturally, emergency responses as a collateral effect was that emergency response services, are the risk of being overloaded too. One important thing which only rehabilitation care providers may have the sensitivity to predominantly is patients with intrathecal baclofen pump. If they're having challenges with accessibility to their specialized facility, because they are at a high risk or they're at a risk of having, withdrawal effects or they have a they have a narrow window of refill at times as well. So this is something which is of major consideration for individuals around the world. Appointment challenges, for example, in the initial phases of COVID, we have to reschedule a lot of appointments. So if you're scheduling like 20,000 or 30,000 appointments in one go, there's always a risk of having to lose few appointments or having to disconnect with the appointments at times. And patients may not be really getting that information well in time, because patients may not be really aware as to what the dynamics have been, because the dynamics have been changing very rapidly on day-to-day basis and sometimes weekly basis too. Medical refills and accessibility to routine care is one of the other issues. So what we saw is that there had been a great deal of inclination towards telemedicine, not only in rehabilitation. I won't go into the challenges of telemedicine in general, but I would just want to mention that what are the unique challenges in tele-rehabilitation, which are particular for tele-rehab. And as I mentioned, that many multiple disciplines are involved. Once we're in a facility where there's a physical availability of providers, that is something else. But in a distant or a remote service, having like 12 different services to coordinate and continuously provide a coordinated care is a big challenge remotely. Similarly, rehab is slightly different when it comes to the need of physical assessment. You really need to prefer to have a visual interaction or a visual assessment with a patient, because you really want to know exactly, how they are physically handling, what is their examination attributes. So that is another factor which, if is being carried out by telephonic consultations, there's one of the major limitations for rehab. Also, as much as spoken to my colleagues, there's a sensitivity towards discussing sensitive discussions like prognosis, which is always desirable, because it's many times it's a permanent disability or lifelong changing event. And such a kind of discussion which may be better off discussed face-to-face instead of a telemedicine consult. Rehab is slightly different because there is always a necessity of demonstration, majority of the times, I would say. For example, how to mobilize the patient from the bed to the wheelchair, how to do intermittent catheterization, how to carry out toileting. These are the things where you really need some expert to physically demonstrate, which becomes a challenge from a remote distance, unless there is an expert on the other end as well who can handle that. So a couple of days ago, when I was preparing the presentation, I looked up for COVID on the PubMed, and there have been about 53,000 apparently publications on COVID. But there has been a lack of research on how COVID is actually having a collateral effect on the non-COVID population in general, especially one of the most vulnerable populations, which is disability care. So it was an eye-opener, I guess, this pandemic for health systems around the world. And one of the major messages is, we need to really think beyond pandemic. We need to really be thinking about readiness for any disaster situations other than pandemic as well. I guess pandemic was an eye-opener. We need to think about natural emergencies, which could be geophysical, and it could be climate related. It could be the extent of it could be much more bigger and beyond that if it's a human-induced disasters, which won't be really, nuclear, God forbid, or so any similar things which can manifest as a disaster situation. Probably we need to be thinking on those lines. From a rehab perspective, in particular, one of the recommendations is to identify regional rehabilitation centers as a backup plan. Always that, instead of having to have one center closed or the centers closed in one area, probably it's a reasonable idea to have, identify one center that in case of a disaster situation, we would have that center be fully operational, and maybe the manpower can be mobilized from the rest of the rehab resources to that particular center in different regions or states or province, depending upon the health systems. I think this is a wonderful opportunity to develop and standardize tele-rehab services across the world. Yes, we have had a lot of institutional guidelines, local guidelines on COVID per se, but I think, again, going back, we need to think beyond COVID, maybe in a pandemic or disaster situation. I know that there's a disaster relief, disaster rehab committee and the ISPRM as well. Plus, not only that, I think there needs to be institutional guidelines that, all right, so this is where we are focusing on the COVID or the pandemic or disaster situation, but how are we going to manage the collateral outcome or the collateral effects on other populations, especially disability population as well. So there need to be a standalone guidelines or standalone operational plans for the other population too. And that can be carried out probably at national level across the globe. So maybe different health sectors, because every health system has different challenges and they have their own infrastructure. So different stakeholders can be, organized to identify disability population as a special and high risk population. I think the one of the major intervention is not probably the structure of how things are going to be arranged. I guess one of the major intervention is a behavioral intervention to help people understand and help the stakeholders understand the sensitivity of disability population during a disaster situation. I think there can be an advocacy at the level of international disability organizations at the platform of World Health Organization. Well, that's pretty much it. Thank you.
Very much, Dr. Ahmad, for highlighting the multidisciplinary approach and nature of rehabilitation and focusing on the fact that rehabilitation is not a system or specific, organ-specific thing, but it goes beyond that. So thank you very much. So can you stop your share and then we can move forward, please? Okay. So now I'm going to start with my talk, and my talk is on rehabilitation perspective in COVID-19. And basically, I'm going to build upon whatever Ahmad has said. And there might be a little bit of overlap, but then I'm going to quickly go through that overlap part. So there are main three objectives of my talk. Number one, is there a role for rehabilitation services in COVID-19? And if there's a role, what is the evidence? And the last, that what is the experience of rehabilitation services for COVID-19 patients all around the globe, and particularly in Pakistan and low middle income countries. Before I start, a little bit of disclaimer. We need to understand that COVID-19 was declared a pandemic by the World Health Organization on 11th of March 2020. This means that less than 7 months have passed before the world was exposed to this pandemic, a global health issue. So evidence is still coming in. And most of the evidence that is available on the role of rehabilitation in COVID-19 is basically based either on small case report, small case series, observational studies, mini reviews, expert and consensus opinion. In addition, most of this published material has come from either from China, Europe, and USA. We do not have a lot of experience sharing from developing countries and Asian countries like Pakistan, India, and Bangladesh. So we need to consider this particular presentation with this disclaimer and background. So Ahmad has just told you in detail what rehabilitation is all about. And I'll quickly go through the World Health Organization definition of rehabilitation, which defines rehabilitation as a set of interventions needed when a person is experiencing or likely to experience limitations in everyday functioning due to aging or a health condition, including chronic disease or disorder, injuries, or traumas. So I'm going to explain how COVID-19 fits in this health condition part or a chronic disease part. And that's why there's a role for rehabilitation interventions, both in the acute phase and in the long-term convalescence phase. So to answer the first question, is there a role for rehabilitation interventions in COVID-19? And the quick short answer is yes. There is a definite role for providing rehabilitation interventions to patients having COVID-19. Now the question is, what is the evidence? Now you can take the evidence in two parts. One is the direct evidence that what has been published in the literature so far in form of small case report, case series, observational studies, which show that different kind of rehabilitation interventions do have some role to play in patient having COVID-19. And then there is an indirect evidence. Indirect evidence means that you can actually extrapolate the evidence generated in the last 40 years on the role of rehabilitation in different diseases. And you can apply that evidence on provision of rehabilitation services for COVID-19 patients. And I'll quickly go through that. And for that, you need to consider that a COVID-19 patient can have generally 4 kind of major issues. Number one, respiratory complications. those of the COVID-19 patient who deteriorate and then they are admitted to an intensive care unit or ICU may develop ICU related complications, neurological involvement and complications, and the general ill health, fatigue, and what we now call as the long haulers of COVID-19. Primarily, COVID-19 is a respiratory pathogen and it involves the respiratory system. And in severe cases, it leads to the classic COVID-19 pneumonia, the ground glass appearance on a CT scan or a X-ray chest. If the condition deteriorates, the patient might develop acute respiratory distress syndrome. Apart from that, we need to consider that there's a category of patients who are already having a pre-existing respiratory disease, probably in form of chronic obstructive pulmonary disease, bronchial asthma, cystic fibrosis, or any other respiratory illness. Now, these patients are at high risk of developing severe COVID-19 related complication. And most of these patients in the above three categories, they are more liable to develop lung damage and scarring. And this would lead to a prolonged recovery period. Again, evidence of the last 40 years clearly shows that there is a role for pulmonary rehabilitation, respiratory therapy, or chest physiotherapy in the management of all these three things. So extrapolating on that evidence and combining it with the new evidence that is coming up, we can say that there is a definite role for rehabilitation in COVID-19 patients. Then patients who are admitted to intensive care units for any reason, whether COVID-19 or non-COVID-19 reasons, they are liable to develop certain important complications like critical illness polyneuropathy, critical illness myopathy. Now, these can actually prolong the length of stay of the patient in the ICU, and it might result in difficulty in weaning of the patient from the ventilator. Apart from that, these patients are at high risk of developing pressure ulcers and what we call post-intensive care syndrome, the PICS. PICS is a relatively new thing, and some rehabilitation professionals are not very clear what PICS is all about. But PICS is something that you develop once you are discharged from the ICU and you go back and start transitioning to your community, to your home again. And that is the point when medically you are fit. Probably you might be having a negative test for COVID-19, but the person is not feeling good enough. And there are three categories of issues that the patient might have in PICS: cognitive, psychiatric, and physical. The cognitive may include like decreased memory, thinking problems, forgetfulness, poor concentration, and trouble organizing the problem solving. The psychiatric impairments may include a PTSD. Imagine somebody on a ventilator or spending some time in an ICU, whether for COVID-19 or some unrelated issue. It is a major physical and psychological trauma. For example, in our own hospital, there was a patient who remained in ICU for 55 days. He actually he walked out of the hospital after 55 days, but remaining in the ICU is a major trauma, both psychological and physical. So patients are more liable to develop PTSD. Apart from that, they might have anxiety, depression, or decreased motivation. And the physical impairment that result as part of PICS include muscle weakness, fatigue, decreased mobility, and difficulty in breathing. Now, this is the point where a rehabilitation professional, the team can come in together and provide service in order to reduce the incidence of PICS and in order to allow the patient a early reintegration back into the life. Initially, it was thought that COVID-19 is primarily a respiratory pathogen and it only involves the respiratory system or the lungs. Lot of evidence has been documented in the last 3 to 4 months that there are certain important neurological manifestation and complications of COVID-19 as well that should be considered, and many of them can be classified as major neurological complication. These might be manifestation of COVID or complication of COVID. It includes stroke, specifically the ischemic strokes, Guillain-Barré syndrome, which is a form of acute post-infectious peripheral polyneuropathy, encephalitis and meningitis, myelopathy involving the spine, skeletal muscle inflammation, confusion, and disorientation. And again, if you extrapolate the information and evidence of the last 30, 40 years, there is a clear-cut evidence that providing interdisciplinary rehabilitation services to all kinds of patients with stroke, GBS, encephalitis, meningitis, myelopathy can improve the outcomes and reduce the complication. So even if the patient is having all these complications as part of COVID-19, there is a definite role for offering them interdisciplinary rehabilitation. A very important thing that has recently come up in the last 2-3 months, and it is important that we rehabilitation professionals give it some importance, is that 80% of patients with COVID-19 will recover with little or no sequelae. Around 10 to 20% are going to go to the hospital, they are going to get admitted, and they might actually end up in an ICU. But again, most of them would recover within 3 to 4 weeks. There is a new category of patient emerging up who are having persistent symptom of COVID-19 even after months having this COVID-19. And this is what we call at long haulers. A lot of debate has been generated both in the layman press and in the scientific article that what is these long haulers, how do they present, and what is the implication of having a person with a persistent COVID-19 symptom for months and months after they have been cleared from the hospital. And just to give you an idea, the patient narrative, look at this. Fiona from US, she's a writer, by the way. She says, it almost feels like I have been hit by a truck at 4 p.m. each day. 4 p.m. is somewhat between the middle of the day. Imagine that you have no energy left to do anything in the middle of the day. Just imagine the kind of fatigue and the kind of frustration you are going to have. And you might want to listen to what Professor Paul Gorner has to say. And Paul Gorner is no ordinary person. He is actually a professor of infectious disease at the Liverpool School of Tropical Medicine, which practically means that this gentleman actually makes his living by conducting research on this kind of infectious disease. So he says, I have had dengue, I have had malaria, I have never been as ill as this illness. And it's really frightening because it's so unpredictable. It's the worst illness I've ever had. I'm still dealing with exhaustion. So chronic fatigue after COVID-19 is a major issue to deal with. And the experts have said that we really have to pay attention now that COVID-19 has created these long haulers. People who go through this for months get really anxious and frustrated and depressed, and they don't know how long they can keep fighting. And probably here is the importance what Dr. Ahmad has said. Look at the bigger picture. Do not focus on the illness itself. Focus on the holistic picture, how that illness affects the person as a whole, the community and the family. And probably you can understand the concept of long haulers. We don't have a lot of data about long haulers in the scientific literature. So far, I was able to identify 2 studies. They're pretty small studies. One is from Italy and the other is from France. The Italian study, they documented the outcome of patient at 60 days, 2 months. And the French study, they contacted their patient at 110 days after their discharge from the hospital for COVID-19. 87% of the patients who were interviewed, and it was documented that they were having at least one persistent COVID-19 related symptom. And these included fatigue, dyspnea, joint pains, poor quality of life, loss of memory, and sleep disorder, which means that, you know, the work of a rehabilitation professional might even go on beyond when the patient is declared free from COVID-19 symptoms or has been declared COVID-19 negative. Coming to the experience of COVID-19 we have around the globe, again, as Ahmad just mentioned, a lot of research has been done and published. So as of today, more than 1,000 articles on different aspects of COVID-19 rehabilitation have been published in Medline. I'm not going to summarize all of them, just to give you the highlights. First of all, yes, most of the rehabilitation services all around the globe, they were either closed down completely or they were converted into isolation or acute care medical units, and the staff was relocated to the medical unit to provide a different kind of service apart from rehabilitation. And those centers who were still providing rehabilitation services, they were having issues with physical distancing. Now, physical therapy and rehabilitation, as Ahmad mentioned, is not just like a consultation, a distant consultation. You have to get close to the patient. You have to provide a certain kind of physical therapy exercises and services, which require a lot of physical contact between the patient. So how would you maintain this physical distancing, right? Then the issue with staffing. So there was an increase in number of ICU units all around the globe, but you have increased number of ICU units or ICU beds, but you don't have compatible number of therapists or rehabilitation professionals who were trained in providing rehabilitation services in the ICUs. And then the challenge with provision of PPE. Then there was a great variation in the rehabilitation response. It varied from early, effective, and integrated in countries like USA, China, and Europe, who already have a very pretty good pre-existing rehabilitation services in place and who had these backup plans as well, to a relatively poor, absent, and unintegrated rehabilitation response, specifically in Africa, which has been documented, and other lower middle income countries, including Pakistan and Bangladesh. The protocols were almost the same, and Ahmad has mentioned this in detail already, that please, you need to understand one thing. Whenever a disaster strikes, whether it is a man-made disaster or a global healthcare pandemic like COVID-19, people with pre-existing disabilities don't disappear. They have their needs which need to be addressed. And it was a major issue which was raised in the last 3 months, that patients with pre-existing disabilities are being neglected because of the reasons mentioned in detail by Dr. Ahmad. And it has been documented in literature as well. And this was a recent report of Guardian published like a couple of days back, that COVID-19 disruption leaves thousands of US stroke patients disabled. So imagine the patient with stroke living in Pakistan probably who might be having all these kind of challenges. Then we have to cater for patient with COVID-19. You need to understand there are probably three categories: the severely ill patient, mild symptom, and long haulers. So obviously, mild symptom patient do not require a kind of interdisciplinary rehabilitation. You might want to focus only on the severely ill, the patient who go to the ICUs, and the long haulers who have been discharged to the community, but they are still complaining of poor health and limitation in mobility and joint pains and poor quality of life. Uh, Protocols were almost the same whether it is a patient of COVID-19 or a non-COVID-19 patient, but the increased emphasis was on staff safety and patient selection. And a lot of guidelines have been mentioned in the literature. These are all free full text available. I would strongly recommend anyone who is about to restart or about to upgrade rehabilitation services in the wake of COVID-19 might want to review these good guidelines coming from all part of the globe. They relate to physical therapy, they relate to pulmonary rehabilitation, they relate to spasticity management during outpatient. They also relate to provision of speech and language pathology services during COVID-19, and also the patient and caregiver guidelines to manage COVID-19 patient at home during isolation. So good material is available out there. You need to do a quick search and you will find all of these. Ahmad has described this in detail, but there's evidence coming up that in areas where rehabilitation services were totally closed down, telemedicine and remote rehabilitation to some extent actually filled the gap. And telerehabilitation in these cases, it promotes the protected early discharge to home, and it ensures the continuity of care for patients with COVID-19 and also for patients without COVID-19. For example, patient with pre-existing stroke, rheumatoid arthritis, chronic back pains, arthritis, and stuff like that. And it is possible to share your complex cases and data with other hospitals and clinics and your colleagues in order to get their perspective and get guidance from them. And obviously, right now, it's not a major issue, at least in Pakistan, but in the initial days, PPE conservation was a major issue. So whenever you are having issue with PPE, probably shifting to a remote rehabilitation or telemedicine would actually help you conserve PPEs. And there are a lot of evidence in the last 4 months that has come up, and I'm only going to share the references with you. So it all comes down to you that what can you do as a professional, as a rehabilitation professional, or maybe even as a non-rehabilitation professional to improve these services. So probably you need to be proactive and you need to educate. So I mean, I know that in most of the cases, rehabilitation professionals were not part of the mainstream acute medical response to COVID-19. I can understand that, but probably it's time that you become proactive. You go to your colleagues in internal medicine, pulmonology, intensive care, ICU, and you educate them and the general public of the value of integrating an interdisciplinary rehabilitation, both in the acute phase when the patient is in the ICU and in the long hauling phase when the patient is transitioning to the community and to the home. Apart from that, you come from different backgrounds, different countries, cities, institutions, and different specialties. All of you have a unique experience, whether you are a student or maybe a resident or a attending physician or a rehabilitation professional providing service. You have your own unique experience. Probably it's a good idea to document that experience so that others can also learn from you and improve their services. And last but not the least, you have to generate evidence specifically both in context of acute rehab and in context of long haulers. So summary point is that although evidence is building up, but there is evidence so far that early rehabilitation interventions can reduce reduce complication, improve outcomes, and different patients have different degree of dysfunction. Apart from that, personalized plans are needed according to the patient age, gender, occupation, physical condition. And the take-home message is that this stuff is real. People are ill. Doctors need to stop diagnosing this as anxiety. We have messed up before. Let's not do it again with long-term COVID-19 illness. Thank you very much. Okay, so I'm done with my presentation. I'll stop sharing. And now we will move on. I'm sorry. Yes, I know I'm not visible because I don't have, this is the what we call Pakistani load shedding. So I'm going to turn off my camera. I just realized I was totally black. So this is a unique experience of presenting in a pitch black environment, but I'm okay with that. So now we are going to move forward to our worthy panelist. And what I'm going to do, I'm going to invite my panelists one by one. So again, they are going to describe their own unique experience of working in their own environment. And then the other panelists can comment or share their experiences, or our audience can chip in and ask questions. So first of all, I would like to request Miss Ashika. She is the nursing director of the Rehabilitation Hospital and acting nursing director at the National Neuroscience Institute at King Fahad Medical City. So over to you, Miss Ashika. Share your screens. Okay, you just give me a second. Just give me a second. I'll share your presentation as well. Just give me a second, please. So whenever you need me to move the slides, please let me know.
Sure, thank you.
Welcome. So here are your slides. Can you see them?
Yes, thank you very much. Thank you.
Sure.
So good afternoon to our fellow panelists, and a sincere thank you to APPNA and Dr. Qureshi for inviting me. And today I really feel really privileged to be able to be talking about our experience with COVID-19 challenges. And I will also make specific reference to disability care and rehabilitation. So just to give you some background, on the 21st of March 2020, Rehabilitation Hospital was converted to COVID-19 wards due to its location. The rehab nurses accepted the challenge and are facing the unknown COVID-19 pandemic with resilience, commitment, and compassion. But before we actually could change the wards into COVID-19 wards, we had around 75 patients that needed to either be discharged home, needed to either be transferred to another rehab facility or a long-term facility, or needed to stay within the city and obviously be moved to another center that was non-COVID. In order to do this, we needed to make sure that wherever we were sending these patients, that it was actually safe for these patients to go home. So if the patient went home, our rehab team went on to make certain that the patient actually received the equipment that they required at home so that they would be able to also to function at home and to continue with their rehab goals. Also, our physiatrists ensured that these patients had their comprehensive medical reports so that wherever they were going, there was continuity of care. When the patients moved within the city to a ward, we strategically moved them to one area because we didn't know much about the pandemic at that time, and we wanted to keep all of our patients safe. We needed for rehab nurses to take care of the rehab patient, and at the same time, we needed to keep the rehab team safe, and we did not want them going all around the city in order to see their patients. So the strategic move was to actually keep rehab patients in one area. And the really great thing about this was that we were able to actually keep them in a ward that had single rooms. So the remaining patients that stayed with us, which were 15, and then subsequently were then discharged over a period of time, had actually been in a single room. The other thing that was really important for us was that we had to not only look at the safety of patients and of the healthcare workers, but we also had to make absolute certain that we were taking a holistic approach to everything. So when the patients were either discharged home, the program coordinators, who are nurses as well, followed up on these patients through their post-discharge phone calls. They also went on to clarify if the patient had any concerns. And the great thing was that they were then able to actually go forward and inform the physiatrist that the patient, if the patient felt that his spasticity had actually returned, they could revisit the medication. Or if the patient felt that maybe he had started up with a urinary tract infection and was concerned, again, they were able to liaise immediately with home health care so that the patient could receive IV antibiotics at home. Now, if I can just move to the next slide, please. Here we had to make sure that as we moved into COVID-19, that the area that we created was in actual fact safe for not only the healthcare workers, but also for the patients, and also for their watchers, because for those rehab patients that were allowed to have a watcher, if the condition justified the need, then they had just one watcher. Here we ensured that the social distancing was maintained. Nursing took the lead in making sure that the triage points were covered. So you had your respiratory visual triage. And then they also made certain that when the patients came through, that they were masked. Initially, as you all know, what you call universal masking was not mandatory, but as we hit the peak of the pandemic, we had to ensure that universal masking was put in place. Prior to COVID-19, there was a lot of initiatives with regards to hand hygiene with patients and the family. Here with the setup, you will see what you call in the first picture, the triage area, visual triage, respiratory area when they come through. And then also with the social distancing in areas where physician and the nurses had separate documentation and work areas. If you can just move to the next slide, please. We also had to make sure that the any healthcare worker coming in contact with COVID-19 was safe. And so here you will see what you call the proper linen and the scrub suit management was extremely important. Nurses that handled our patients made absolute certain that when they did come in, that they had changed into their scrub suit so that they could have a different change of uniform so that they were safe. And before they left the area, they made certain that they changed again so that they did not infect anyone else. Housekeeping was also, it was imperative that we kept them safe. The mask fit test for all individuals is what rehab nurses were assisting with in making sure that we were safe. The use of the PUPA with the help of the nursing education department, we were able to ensure that all of our areas had the mask fit test, and if they failed the mask fit test, that they were able to use the PUPA, and so they were trained on how to use the PUPA. Now, for the patient, for the rehab patient, it was imperative that we made sure that the area for the patients were extremely clean. And so here you will find what you call staff support in cleaning of equipment and making certain that patients were safe. If we move to the next slide, you will see that we had a lot of education and awareness sessions. Here, we have the unit-based councils here in rehab, and one of the things that the registered nurses who are the frontliners had done was actually develop educational material, both in English and in Arabic, for patients so that they could understand what they needed to do, what was COVID-19, what were the risks, and what did they need to do. And so that actually helped patients to actually understand the pandemic or the virus a whole lot better. With regards to psychological support, a lot of clear explanations had to be given to rehab patients. Online counseling was done. But what we found to be the most important was that for a rehab nurse, the carryover of skills that patients had learned in therapy, bringing it to the bedside, is what actually got us through the COVID-19 pandemic. Right now, we still have, our 17 patients that are COVID positive, and the rehab nurses are still going since March. And if I take you to the next slide, you will see that I actually have a success story. And the patient in the picture is actually the husband of a staff member of one of our rehab nurses. And here the patient had really, really bad COVID-19 in the sense that he ended up with the COVID pneumonia. And because of his comorbidities, he actually had to be ventilated. And he was in ICU for a period of 3 weeks. When at that point, at the height of the pandemic, a lot of our therapists were not able to go through and actually give this therapy that the patients actually required in the ICU. And when the patient returned to the ward 3 weeks later, it was the rehab nurses that actually asked the PT, the OT, the physiatrist as to what were the things that they could do. And so they were the individuals who were actually working with the patient to help him with the range of motion. And what was really great about this here is that this patient, whom we thought would not make it because he was so critically ill, is today driving himself to work. He's a nurse and he's able to do his job again. And that has been really the most important. And I think from my experience, rehab nurses are really instrumental in making certain that the carryover of skills that patients learn in therapy is absolutely important in any care of a rehab patient. And I think that is one of the most important things that we have learned as nurses. And also, whilst the pandemic, yes, everybody is nervous, there's been also a really good side to it, in the sense that rehab nurses elevated their knowledge, they elevated their skills, and they will be able to take on now more acute rehab patients. And this makes us really proud because we've elevated ourselves to the next level. And yes, whilst the pandemic and the virus is not something that anybody looks forward to, you also have the pros where you actually learn, and then you know what you can do even better the next time something like this occurs. So thank you. Thank you.
I'm sorry. I think I was not unmute. Sorry. So thank you very much, Ms. Ashika, for sharing your unique experience of rehabilitation nursing and providing service to these COVID-19 patients. Now we'll move on to our next panelist, who is Dr. Taha Ali. And now we move on from Saudi Arabia to Australia, and he is a consultant physician in rehabilitation medicine at the South Australian Spinal Cord Injury Service, Royal Adelaide Hospital and Hampstead Rehabilitation Centre, Australia. So, Dr. Taha, can you please share your experience? Thank you very much. Over to you.
Thank you very much, Dr. Rathore and Dr. Qureshi, for a very informative discussion in regards to COVID-19 and its impact on rehabilitation. We are very fortunate in Australia that we are one of the less or least affected countries from COVID-19. So I'm aware of the time constraints, so I will just briefly summarize our experience in Australia. So I'm working in South Australia, in Adelaide. As we know that the Australian population is about 25 million. We have about 3.2 people per kilometer square compared to Pakistan, where the census says that in Pakistan, you've got 256 people per square kilometer. So implementation of social distancing and hand hygiene measures were relatively easier compared to some of the densely populated countries in the world. So far, we have about 27,000 cases of COVID-19 in Australia, and the overall mortality to date is 870 people. In South Australia, where I practice, we have 468 cases, and we only have 6 deaths. So we are very fortunate from that perspective in terms of COVID-19 effect. At this stage, Victoria, which is the neighboring state to South Australia, is currently in stage 4 lockdown, but their number of cases are less than 50 per day, and we are hoping that the restrictions will be eased off very soon. In terms of our measures to limit the spread of COVID-19 during the pandemic, we obviously done the standard measures that include monitoring our staff and patients and ensuring that the staff were screened at the beginning of each shift. We were quite lucky that the rehab centers were not shut down as it happened in some of the other places in the world. The most of the rehab hospitals were fully functional during the COVID-19 impact. However, we've done some measures to ensure that the infection was not spread across the sites. So we provided therapy in the room where possible, and we also limited the number of patients being treated during that pandemic in the common therapy areas. The non-essential therapies were canceled, including outpatient therapies. We used dedicated equipment, and special emphasis were used for cleaning those equipment and ensuring that the procedures were performed using the cleaning, all the cleaning adequate strategies. The borders were closed between the states, so there was less risk of cross-border transmission. PPE were used especially where there was a risk of aerosol transmission. The visitors were restricted, so we only allowed one visitor per day to visit the patient. We opened special drive-through COVID-19 clinics for the testing, and the staff were fast-tracked. The government also introduced a role of COVID marshal, which is basically a civilian that was trained and work alongside police to make sure that appropriate and adequate measures were taken to implement social distancing in the community. Also, we have obviously used telemedicine during that pandemic, and we're still using telemedicine for our non-essential OPD visits, as well as we've conducted our case conferences, our multidisciplinary meetings, our unit business meetings, as well as our neuroradiological meetings during the pandemic. Very interestingly, what we have discovered during the pandemic, that although we have less cases of traumatic spinal cord injury because of obviously the restrictions and people were encouraged to travel, we have seen more cases of epidural abscess during the pandemic, and there was significant high number of patients who were presented with epidural abscess, young, older population as well. And so far, we haven't able to find out any link between the pandemic and epidural abscess, but whether it's a coincidental finding versus there's any link. There was some speculation whether there's any sort of decline in immunity during the pandemic. So at this stage, we are working on this in consultation with the ID department and the spinal surgery unit to find out whether there was any change in that, what was the main reason of the change in that pattern. And in terms of future, from the COVID-19 challenge, although we, in some places, we're still currently overwhelmed by the speed of infection of the pandemic, it is now vital that we start to prepare for the aftershocks of the pandemic. The notion that patients surviving intensive care and mechanical ventilation can be discharged home without further medical attention is a dangerous illusion. So as Ahmad, Qureshi, and Dr. Farooq has just mentioned, and Ashika has also covered her experience from Saudi Arabia, the role of rehab is not only limited to provide inpatient rehab services, but also to include provision of outpatient services, looking at the physical, psychological, as well as cognitive deficits using that biopsychosocial model of care, and to focus on community reintegration for those patients who have recovered and have been discharged into community, using the curative as well as compensatory strategies to make sure that they have returned to community and they are again being utilized in the community in terms of their return to work and being useful members of the society. Thank you very much.
Thank you, Dr. Taha, for sharing your experience from Australia. Due to paucity of time, I'll move forward and then we'll take the question and answer at the end. Now I will invite Mr. Ahmad from Ireland. He is a senior physiotherapist at the Meath Children Development Team, Health Services Executive in Ireland. So can you, Dr. Ahmed, please share your experience of providing rehabilitation services COVID-19 from Ireland? Thank you.
Thanks million, Dr. Rathore and Dr. Qureshi. Just a quick introduction that this Meath Children's Development Team is a part of HSE. HSE is a healthcare provider in Ireland. So that means the Meath Children's Team is part of that, and it covers one county of Meath to provide disability rehabilitation services to children from any age. We have around 35 3,500. Around that number, the children who are registered with us who have pre-diagnosed disability, which can be very minor disability to extremely complex cases. And it's an interdisciplinary team, and similar teams exist in other counties as well. It's a state services, so all cost is borne by the state. So that was a quick introduction. As a team, it links it with the acute services through 2 major hospitals in Dublin and 1 rehab, intensive rehab hospital in Dublin for their consultants consultation and all interventions. If I divide quickly the COVID-19 phase into 3 phases quickly, and quickly I will go through, I know the time constraint. The first phase, which started around the middle of March with the lockdown, and all services were suspended. A lot of staff members were redeployed and retrained to do the other things which they were not previously trained. So most of the staff members were either redeployed to ICUs or step-down facilities, or even in the testing centers. So that was the initial phase. So very limited staffing level was available for providing actual rehab or therapy services to the children. At that stage, the most of the consultation of therapeutic consultation was relied on phone consultations or video communications. Access programs were reviewed on phone or on emails, and equipment very urgent. The prioritization was completely changed. So urgent equipment reviews were only done, and arthrotic and orthopedic interventions, elective procedures, Botox, these all services were suspended. So that has huge impact, which I discuss later. The phase 2 was from June to nearly August and mid-September, when the things were calming down, and we were able to see limited access to face-to-face appointments. For example, we started home visits, some of the clinical settings, which we provide services in different clinical settings in County Meath. Some clinic settings were opened after risk assessment, some couldn't because they need a good amount of work to be done to open. So redeployment was decreased, so a lot of staff members were available. So we started providing basic kind of services for very high priority patients. Some of the elective procedures started with a huge backlog. Orthotic services were started. Positioning and equipment reviews were started as well, but there was a huge backlog. We are in phase 3 at the moment, from the start of September, and the surge is starting again. So there is a little bit more redeployment again started, but now HSE has contracted a software company who has supplied us with data protection software for Attend Anywhere to provide virtual sessions. So we started with virtual sessions, which are very like a kind of telemedicine, and now our 85% sessions are virtual on Attend Anywhere, where you can see a child doing his exercise program, his positioning, his equipment review. If there's minor adjustment, you can guide the parents to do that adjustment. And hospital elective procedures are still ongoing. Lengthening procedures, Botox, spinal surgeries have started and they are ongoing. Arthrotic services have been started, and so a lot of things are still ongoing, but there's still a kind of unpredictability in the future because the cases started surging again. The effects on our client group, as Dr. Qureshi said in his detailed presentation, the collateral effects. I like this this word, collateral effects, due to delay in equipment and procedures, elective procedures, Botox, lengthening. It has huge impact in some of our caseload, especially with the complex children. their range of motion has reduced, their posture has deteriorated during their last 6 months. Some of them who need special equipment to walk, without those equipments, they were unable to walk, and so reduced their mobility, and some of them may not able to walk again. So these, their standing programs were inhibited. Though there was no restriction on limited going outside. So some of the parents were very innovative, and they keep their children on their walking walk on their feet in an innovative way to going out. It's not only physical effect with range of motion limited postural issues. There were also a lot of psychological effects, especially with the children who has psychological needs like intellectual disability children and children who has autism spectrum disorder. They have huge sensory motor issues, and that was that really affected their family setups, their more burden on their parents. As Dr. Qureshi said, the caregiver exhausted. We have seen practically, because the caregivers are usually provided part-time to the families who have very complex children or people at home. Those care was not provided during this time because of the COVID and the vulnerability of the patients as well, because they are on a lot of them are high risk group. So those services were reduced, putting extra pressure on the parents and the family members to provide that care facility, which was partially provided from outside. Severe backlog on our services, therapeutic services, arthrotic services. A lot of companies which stopped working before they started, but still a lot of backlog in their equipment servicing or providing or supplies. Hospitals in Dublin they have a backlog in their appointments, mostly the tendon release, Botox, spinal surgeries, hip surgeries. They are delayed and they're still waiting, and that backlog is affecting on them. We had funding issues at the moment to buy necessary equipments, but availability of clinic space is very limited. So we are not at our full capacity yet. The collateral damage is huge. I will say that we have to, even if tomorrow the COVID pandemic finishes, still I will say that maybe it may take more than 1 year to just cope with that backlog and collateral effect of this COVID-19 on our disability services, especially on high risk groups. Thanks million for giving me opportunity and listening.
Thank you very much, Amir, for sharing your unique experience of working with pediatric disabilities, the role of Tele Rehabilitation, and how you manage this issue in your own unique circumstances. So thanks once again. Now we move on to the last panelist of the session, and we move back to Pakistan. I would like to invite my colleague, my friend, my brother, Dr. Zaheer Nasir Mansoor. He's right now working as a consultant and head of Department of Rehabilitation Medicine at the Combined Military Hospital, Okada. But a couple of months back, during the heat of the movement, when the COVID was at its peak in Pakistan, he was working as the member of the core team at the Armed Forces Institute of Rehabilitation Medicine, Rawalpindi. And he was part of the team that actually helped convert that large tertiary care rehabilitation institute into a COVID-19 center. And he, along with all of the team members, provided unique services. He has actually published his data on that as well. He's also a medical educationist and a trained pain specialist. So Dr. Nasir Mansoor, over to you for sharing your experience of managing COVID-19 patients during this pandemic.
Thank you very much, Dr. Farooq, for invitation. And I would like to thank the APPNA MERIT as well for inviting us as panelists. And the topic today was challenges in disability and rehabilitation in COVID-19 situation. But at the moment, I'm feeling that the challenge of being the last presenter in any session is much greater than that. So talking about the response of rehabilitation services towards COVID-19. So as Farooq mentioned, I have the honor to work in the largest tertiary care rehab center in the country while the COVID-19 pandemic was at its peak in Pakistan. Listening to the presentation, the very elaborate presentations by Dr. Ahmad and Dr. Farooq, I would just second them. Whatever they were saying, based on evidence, I can prove it that I have witnessed all those things while on the ground, right? So what happened in the major rehab center in our country? As you all know, as it happened in all the other countries, like a countrywide lockdown, sudden lockdown, halting of all the services, indoor and outdoor rehab services. At the same time, our 150-bedded rehab facility was taken over by the acute care settings and converted it into a 100-bedded isolation facility for COVID-19. So majority of our own patients, they were either discharged, sent back to home, and a very small number was left. And even they were reluctant to stay once they got to know that COVID-19 patients are going to come to this hospital and will be staying here. So a good number of them, they left by their own choice. They left the hospital. So coming to the challenges faced by the institute, I would say the first challenge was the training part. Like, we are a rehab setting, we have got our own set of skills, our own set of expertise and a working methodology. So suddenly converting the same manpower to an acute setting, so we need to train them into PPEs, personal protective equipments, disinfection, and everything had to be revised and trained and deliberated to the staff. At the same time, we were having a scarcity of these at the national level, and the costs were skyrocketing. So what innovation we did was that we converted our artificial limb workshop and the orthotic and prosthetic section, where we have got a lot of skilled manpower. We utilized them and we started producing our own PPEs. We procured the raw material from the market, and we started making our own protective equipments, the face shields, the masks, the PPEs, and that's how we managed the scarcity of the PPEs. We even provided it to some of our sister institutes as well, the PPEs. Then coming to the patients, our disabled population, or the patients were dependent on our rehab setups. So they were also prone to these COVID-19. 3 of our spinal cord injury patients, they developed COVID-19 either during the transfer, because they were being shifted from some other cities towards our rehab center. So on their way, they got infected because they were traveling on public transports. At the same time, like more than 25 amputees who are planned for rehab, once they fall back to our institute after the acute phase were over, 25 of them they had COVID-19 positive while they were back home. So no population was immune to COVID-19. It affected everybody, and with impunity. So for the first month and a half, all the services were at standstill. But gradually we started off with limited OPDs, with full protocols for PPEs for both the attending physicians as well as the screening protocols for the patients. Then we have got full-fledged protocols for all the diagnostic procedures, like electrodiagnostics, using full PPEs. Patient had to have their COVID-19 negative test in order to get their electrodiagnostic testing done. Limited number of therapies were initiated after 1.5 months of the lockdown, and with full protocol. Telemedicine, somehow we couldn't do it on the institutional level, but on personal level, we gave consultations to a lot of our patients who were in acute pain or who needed some consultation in terms of their medication or in terms of their symptoms. So that helped a lot in our patients. Coming to anxiety and depression among the staff, We're conducting a small study as well on our own staff as well. So it was astonishing. We are going to publish that as well, that almost 100% of the staff who are working directly with the COVID-19 patients while the facility was converted into an COVID-19 isolation facility, they were having from moderate level of anxiety and insomnia and all these things, and we checked them on validated scales, and we're going to publish that as well. So 100% of those dealing directly were having moderate level of anxiety and depression, while those in challenges faced by the patients, like in the lockdown, the whole services were stopped. So the patients didn't have the facility to get the refill, the medication refills. So that was an issue. Then the patients having chronic illnesses, like they develop complications. Those who were on regular treatment, like therapies, and coming on day visits to the hospital for like weeks or months, when everything was stopped, their spasticity increased due to non-availability of medication and non-availability of therapy and modalities. So they develop complications like contractures, spasticities, UTIs, and other conditions. So that was an issue from the perspective of the patient. And then another very important thing, like Ahmad said, that when the pandemic came, the strokes didn't stop, the MIs didn't stop, the road traffic accident didn't stop. So at the same time, the pain management was a big issue. All those patients requiring acute pain management, like having acute radiculopathies, acute sciaticas, neuropathic pain that need urgent attention, they were having problems in getting to the hospital and getting treatment. The psychological aspect of isolation and the COVID-19, I already deliberated. So I would just like to say that all those complications related to COVID and non-COVID patients, like especially the COVID patient, like the critical illness polyneuropathy, the critical illness myopathy, we have witnessed them. We have witnessed the long haulers as well. One of our colleague doctors who got positive and was repeatedly getting positive even after 2 months, and he was having very bad symptoms of this fatigue and anxiety, and these problems were there. So we have witnessed that as well. And I can quote one of my patients. He was a practicing lawyer about the pain and the myalgias. According to him, it was the
Hello, Nasir, I think we have lost you.
in the end, I would just like to say that we need to learn from all these disasters, and we should prepare for them. But at the same time, I think we should not wait for disasters for our own improvements. So thank you very much.
Thank you very much,
Farooq. I'm done.
Thank you very much, Nasir, for sharing your experience of providing rehabilitation services during this pandemic. Now the floor is open for question and answer. There are two ways you can do that. Either you can ask or type your question in the Q&A box, or you can raise your hand digitally and I'll unmute you and you can ask your question in person. While you are writing your question, there's one question from the audience that has already been asked. And the question is that how can we help the long haulers in COVID-19? So Nasir, since you were actually talking about those long haulers and you just mentioned two examples, so can you elaborate further that how can we help these long haulers? How can rehabilitation team help these long haulers, which are usually neglected and not like acknowledged in the medical community so far? So any thoughts on that? Dr. Nasir, please.
Right, thank you very much, Farooq. I had witnessed only this one case that we call a long hauler, but his only symptoms were like this fatigue, anxiety, and this body aches and feeling unwell feeling due to staying for a long time indoors in the hospital wards. So I think we just gave him some time off from the hospital, advised him some good nutrition, and physical activity, gradual resumption of physical activity. He didn't have any acute medical thing like no gross changes on his X-rays or HRCTs or stuff. Otherwise he was good. So the only thing that we could do was this reassurance, giving him some time off, and gradual resumption of his physical activity, and he felt better afterwards. But I think we need the point, whatever is the core issue that's causing it. If there are changes in the lung, if there is ongoing infection, if there is some secondary thing going on, we must be treating that beforehand.
If I may add 2 cents there, I think one of the things that we really need to look into is the delayed complications, especially the neurological complications. Sometimes they're very subtle and they may not be able to be picked up during the acute care, because during the acute care, naturally the focus of the whole team is towards a specific organ damage or specific system damage treatment. Some of the neurological complications, which are very subtle and maybe associated with debility in general, they may show up when the patient actually goes back home and they're trying to integrate and mobilize a little bit. So one of the things I think which may be introduced during a pandemic is as standardized tele rehab services. So, Dr. Nasir, I wanted to ask, what is the possibility we can optimize tele rehab services or telemedicine services in Pakistan? I had a brief chat with Brigadier Ahmad as well, and technology is not a problem when it comes to military services in Pakistan.
So I think it is very much workable. We have already started these tele rehab services in our CMHs and MHs, but not in the rehab setups. So we can just copy that model, and it's a very feasible thing. Like, people got benefited from it a lot, especially during this pandemic, and even home services for provision of medicine were provided. So online consultations, teleconsultations, video conferencing, all are possible, and the systems exist in our sister institutes, and we are going to replicate that. It's very much doable and very much practical thing.
Thank you, Nasir. Since we have overshot our time already by 30 minutes, so Ahmad, should we wrap it up?
Yes, I think we should.
Yeah. You're mute, Dr. Ahmad.
No. It's probably problem at your end. Ahmad is audible. So
yes.
First of all, I would like to thank everyone. I would like to thank APPNA MERIT, Waleed Zafar, Dr. Danish for their fantastic contribution toward this online teaching. And surprisingly, I just came to know that this was the 50th live webinar series in this APPNA MERIT program. And now for the closing remarks, I would like to request Dr. Shahid Rafiq, who is chair of the APPNA MERIT program. He's the guy who made all this happen. So please, if Dr. Shahid Rafiq, you can simply say some closing remarks that would encourage all the participants and the panelists. Over to you, please, sir.
Thank you. I'm very honored that this was the finale, I would say, and it happened to be the grand finale because rehab is very close to my heart. I'm a stroke specialist in addition to being a neurologist. So rehab is, a very, we respect physical therapists, occupational therapists, speech therapists, I think more than any other discipline in medical field, because we see, when I see those stroke patients in my office, in my clinic, after months and continue to follow them after months and years, I see the difference that the rehab and physical therapy and occupational therapy, speech therapy has made. So really, it deserved to be the grand finale of this series of 50 webinars. This all started with COVID, and of course, although the concern and a great concern is still there, the disease has not gone. But initially, as all of you know, there was scare. More than a concern, it was a very scary new phenomena, new disease, which nobody knew how to handle, and we learned together. So we started bringing specialists from across North America, and then of course UK and Australia, and so international medical diaspora and from Middle East got together and with the Pakistani colleagues, and we discussed. Actually, in the beginning, this program was daily, and so at night about I think 11 p.m. here and 8 a.m. In the morning in Pakistan, and then in Ramadan we changed the timing to weekends, and then afterward again weekends, and then one day. So these have been really great for all that purpose. Fortunately, Pakistan survived well, and hopefully the winter will not bring any more problems. But this series has been very well received, and not only that, but it actually brought friends together, meaning that the international faculty, be it a rehab or neurologist, pulmonologist, cardiologist, nephrologist, and all sorts of multidisciplinary team emerged from this, and MERIT, which is a committee of APPNA, and the focus of it is in medical education and healthcare in Pakistan, became stronger because we came together, and now it led to many different programs, different courses, and actually after this we are inaugurating what we call APPNA Academy, and this will house all the courses that we are going to develop. We will be inaugurating stroke course, and of course rehab is a big part of that, and Dr. Ahmad is one of the faculty, and there is a rehab module in the stroke curriculum. So that would be inaugurated. There's a point of care ultrasound course that will be inaugurated. Then in place of this, actually on Saturdays, there will be a series of family practice, different discipline, different topics, and that will be a 1 year. So of course that probably will be recurring. But if we would love if this team of elite people like Dr. Rathore and Ahmad and all the panelists can come up with some kind of continuous course or workshops that can be done online. Of course, there are limitations, but I heard myself that there are online physical therapies, speech therapies, cognitive behavioral therapies, and so those kind of softwares are available. And if we can adapt them for Pakistan and even here, or how we can develop maybe a 3 months course or longer or shorter, that would be great. So that's our focus, APPNA MERIT's focus, that all disciplines should create whatever they think, because I am not a rehab physiatrist, but whatever you think can be done online and it has an enduring benefit, then that course can be housed in APPNA Academy and can run and rerun so that the more and more people, I think this is the most cost-effective, it will be most cost-effective way of transferring the knowledge, skills, training, and technology. Of course, technology Pakistan is coming up with, or there can be donations of some sort later on, but the training and the skill is very important, because there are a lot of places in Pakistan which have a lot of sophisticated equipment, but there are no people. For example, ICU, intensive, ventilator is a good example. There are more ventilators in Pakistan than the intensive care specialists. Of course, one ICU specialist can run more ventilator, but still it is outnumbered. So we need to transfer the skills, that we need to transfer the knowledge, and that's what APPNA MERIT does. Again, I'm very appreciative of this effort, this webinar. and all the attendees. I always say that attendees make our program successful, because without them, no program can be successful. So thank you all. Assalamu alaikum. Stay well.
Thank you very much, Dr. Shahid Rafiq, for your encouraging comments and acknowledging that rehab is part of the bigger picture. So before we break off, just a couple of important announcements that the APPNA MERIT host have shared. A couple of important links. So these are links to the YouTube channel. These are links to the Facebook page and the WhatsApp group of APPNA MERIT. All of you are strongly encouraged to click those links and become member of those channels and follow those pages, so that you can remain updated about the future programs of APPNA MERIT Academy. So thank you very much, everyone, for attending this very enlightening and more than 1.5 hour program. So Ahmad, if there are any ending comments from your side, or else we can close it down. Thank you, everyone. Assalamu alaikum.
Yes, thank you very much for all the panelists. And Dr. Shahid, it had been those were very encouraging remarks, actually, because there's a lack of identification of the concept of rehabilitation in many health systems around the world. And I think there's a considerable margin that we can contribute in whatever capacities we can. And inshallah, we look forward for that. I think it had been a great day. And especially, we are at different time zones. I would especially like to thank Dr. Taha, who had been joining us from Australia at midnight. So special thanks to him, and good luck, everybody. Thank you.
Thank you, Ahmad. It's a pleasure to be part of the team.